We are now going to our final presentation before starting the discussion, and final panel member is Mrs. Malati Jaswal, who's going again to talk about RSBY, and more specifically the role of RSBY in the wider endeavor of universal health coverage. Mrs. Malati is a consultant in health insurance, and she has been working with the insurance industry for more than 25 years. So I think it would be very interesting to listen to her point of view on this public program. Mrs. Malati, please, the floor is yours.
Thank you, Bart. Good afternoon, everyone. I think, first of all, let me say thanks to the organizers for inviting me and giving me an opportunity. As we can see, insurers are not, my tribe is not popular here. So I'm the only person facing the whole tribe of scholars and public health specialists. I think I need a little bit of bravery to be here. Thank you very much once again. And I worked in RSBY as an implementer and as a with the ministry GIZ in capacity building and fraud control. Of course, the views expressed are completely personal, and they are not impacted by any other organization. I would try to skip some of these slides because we have had overdose of RSBY in this session, and I would try, and it was 15 minutes, now it's 10 minutes, so I'll have to cut it short even more. And I think I wouldn't go through this slide. Let's skip it. Scheme in brief, I think everyone has spoken. Beneficiary pays only 30 rupees. It's meant for BPL people. It covers 30,000 inpatient care, and there are 1,000 packages and daycare procedures which are covered under the scheme. It's a cashless transaction anywhere in India. I'll explain all the issues that have been discussed by the previous speakers. And their travel expense reimbursement and free food. This is the scheme in brief. And as you can see, that RSBY is neither a miracle nor it offers everything. It offers a limited extent of secondary care. Its mandate is nothing close to a comprehensive care. Its mandate is not, it's neither priced like that, it's neither designed like that. So when we say catastrophe is not covered, it wasn't meant to cover catastrophe in the first place. When we say primary care outpatient, it was not designed to cover like that. Maybe in future it will expand, but currently the scheme was not designed like that. The stakeholders, I think it has interwoven a good team of central government role in policy guidelines, funding, IT framework, overall direction, state government in data preparation, tendering, funding, monitoring, grievance redressal. Insurance companies underwrite the risk. They are the carriers of the risk. They enroll beneficiaries. Empanel hospitals settle claims, run the kiosk. Empaneled hospitals provide cashless treatment. And the TPAs and smart card service providers, they do the field level implementation. So you see there are 5-6 key stakeholders, and each one is intertwined with each other in a very peculiar sense that this is, I think, one of the models on which the scheme exists, and which is I think much used and abused word also, a PPP model. But I think I wouldn't say that it is abused in this particular case. It has been used rather well, I would say, to the advantage of all. I don't think the efficiencies the RSBY could bring about would have been possible to bring to this scale in 4 years' time for any scheme in India. At least none of us might have witnessed that in our lifetimes. There are checks and balances. The scheme works on checks and balances. There are business interests which work as cross-references. Like, for example, in the interest of insurance company to enroll maximum people, in the interest of hospitals to treat maximum people. But the insurance company keeps a check that the hospitalization doesn't go overboard because they are the ones who have written the risk. So there are checks and balances which are there. Of course, nothing operates in an ideal environment, and I wouldn't say that all those checks and balances work in perfect harmony. And robust technology framework, I don't think there is any scheme in India. I am from the insurance industry, I'm not from the health sector. But even in the insurance industry, we pride ourselves for the last 10 years on the IT framework. But nothing which beats RSBY, I think nothing beats RSBY in technology side. It's completely paperless, completely cashless. To give you a perspective, like the regular health insurance, the private health insurance started in India in '86. And from '86 to 2012, we have covered around 7 crore people, around 6 to 7 crore people in 25 years plus. And RSBY has done this 10 crore people in 4 years' time. So you see the scale. It would not have been possible if it was driven on a traditional paper-driven manner. So it is paperless, cashless, and the interoperability across country. I would not say that there are no issues with interoperability, but if I was to buy a policy from United India and try to claim from New India in a regular policy, impossible. No way. No hospital will entertain me if I have a policy of Royal Sundaram and I go and claim from a hospital which is insured under New India. But here, anywhere in India, you go, the card works. Of course, there are issues, there are teething troubles of a scheme of this kind, which would always be, and then I think at the back end, the technology getting improved, it would be a little bit of smooth. Standard rates for medical procedures. I think this is one of the struggles India has. We are no standard treatment guidelines. There are no standard costing of care. There are no standard, quality benchmarks. So this is the environment in which we work. In that, we have standardized 1,000 procedures as a very low-cost healthcare delivery. I think it's one of the best examples of what standardization could do in processes, in technology, in procedures. Accountability and transparency. If a scheme is paperless and cashless, if everything is online, how can it not be transparent? How can it not be efficient? How can, once things are transparent, accountability is there. If I don't look at the data, it's my problem, but data is available to everyone. I think every researcher can access that data. Every state government can access that data. Every moment, right this moment, if 10 claims are hitting in 10 districts, those are available for anyone to at a click of a button. I don't think this, more than this transparency could have been brought about in any scheme in India. And beneficiary empowerment. I think she mentioned about, even I have traveled to Meghalaya, to Gujarat, to Chhattisgarh, a lot of places in connection with RSBY. And most of the doctors, and even we people who are living in cities, we have preferred hospitals, we have preferred doctors, we have trust and faith. Those logics work everywhere, number one. And number two, mostly people, we have seen that they prefer not to use RSBY card when they think the ailment is a small one. They keep it saved. They save it for a surgery. They save it for a treatment where they need to go to the private sector. And we all know, I think any one of us should visit a public facility to know what it is to be treated indifferently, to sit there for hours, to wait for the doctor, to wait for the drugs to arrive. And I think it's less than 2 months back, I went to Chhattisgarh in connection with the hysterectomy cases, and I met two of the beneficiaries. They had delivered cesarean in one of the private hospitals in one of their districts. And I said, why did you not go? You have come far off. Their husbands were there. They were young couple, hardly 22, 23-year-old. And both of them, they were from different blocks. They said we had gone to PHC, we had waited there. One of the boys, I would say boy, not man, he said 8 hours my wife was in labor and nobody attended to her. So I took the private ambulance and brought her here. So this is the apathy which people face, and no doubt the surgeries are done in private sector because people feel more assured of getting treated there. A little bit about the efficiency. I think the prices were kept at 750 rupees by the government, but I think competition has driven it down and down and down, and it is now standing at 377. In fact, to the insurance industry, to the regulator, it is a bit of a worry that this is an unsustainable pricing, but it has done wonders for the government. I think they have not spent a penny extra than they would have spent. Had they doled out 750 rupees to the insurance companies, we would not have had the competitive pricing determination which has been brought about through bidding process. And I don't think any scheme in the world or any scheme in India can offer a 30,000 care in 400 rupees for a family of 5. This is the level of beneficiary enrollment in round 1, varying, I won't go, there are various reasons for varying performances, state government initiative, TPA's involvement, and the beneficiary level of education. But I think given all these circumstances being together, even within one state, the different insurance companies behave differently. and sometimes the enrollment improves in round 2. Mostly it has improved. In very few cases it has dropped down if there was no utilization in the previous round. Utilization is also going up. It was around 2%, now it is 3.83%, which is a good sign. I think that's a sign of increasing awareness, which is how I think most schemes would be. In first year, there would be less utilization, and as the scheme is maturing, male-female enrollment, there is not much of a worry on that count. I think the enrollments were a little less for females, but the utilization for females has been fairly good. Maybe the females of the household, which were poor, denied access, they are now getting the advantage of having a free treatment. Average family size is 3.6 on all India basis. Let me correct, it's not 5 on actual. It allows enrollment of 5 people, but actually when you do the enrollment, when you go village to village, half the people don't turn up. I have been myself, in the implementing teams. It's not that the TP or the insurance company don't want to enroll people. They would like to enroll as many as it makes business interest. And there is a lot of pressure from the state government and the central government that the family size should not be less than 2 or 3. But if you look at the data which is given to the insurance company, the family size sometimes is 2.1, which is in itself is inaccurate. So they try to improve there are dummy entries which are kept for the family members, which are then corrected at the time of enrollment. Now gradually starting from 2.4 as the family size, now the all India basis, the 3.6 is the current family size. So when we say we have issued 4 crore cards, so multiplied by 3, around 10 crore people have been insured in RSBY, 10 crore plus people. Within the larger picture, there are huge variations, and those are the challenges which these two, I think, studies have proven, that within the state, there is the utilization is very different. In Kerala, utilization in Assam is very different, utilization in Gujarat is very different. Culturally, people's access to care. I was in Meghalaya, and then they said that people don't want to be photographed there for some reason, that they think it's anti-religious. So even to come for the photograph of the card, they think that this is something not religious. The religion doesn't permit. It was a strange revelation. I think in May I had gone there. So there are various reasons for, this is not to put everything on the beneficiary, that they don't come forward for the utilization or for the enrollment, but it depends on the insurance company, on the state government's own initiative, on the monitoring, on the icing, on the awareness building. There are, of course, the outliers, which are excessive utilization in some districts in UP, Bihar, or in Kerala, which itself is also another worry of the extreme. But I think at present, the insurance companies and the government is more worried about lower utilization than the fraud control. I'll come to fraud control a little later. Private versus public hospitals. RSBY today has around 12,400 hospitals, out of which I think 3,000 will be public hospitals. It is the sheer apathy, I would say, in some states that the public hospitals do not participate. The average claims cost also varies. The average claims cost of public sector hospital is much lower than the private sector hospitals for the various reasons that surgeries are performed normally. If you look at the claims data, 80% surgeries would have been performed in the private sector. That is how the average claims cost is also very different. Insurer burnout ratio, we saw that the premium is coming down. Naturally, the burnout ratio is now more than 100%. Which makes the scheme a little bit doubtful from the insurance company perspective. We do not know. There would be price correction. It has happened in Kerala. It will happen in other states as well. Some things on the key challenges which the scheme faces is beneficiary awareness. There is a huge issue regarding, can I get 2-3 minutes more? Yeah. Please. There is a huge problem regarding beneficiary awareness, like even if you have local language pamphlets, even if you do dum-dum public announcements, wall paintings, it is a huge scale effort to make beneficiaries aware, to have a mechanism by which they would come. There are radio announcements, jingles, street plays, nukkad natak, you name it. I think RSBY has tried it, everything. So beneficiaries awareness continues to be a challenge, and now at the central level, certain agencies like PAC and UNDP have been involved in this exercise. They've also been involved in another exercise, which is capacity building. I think capacity building as a country, I mean, I am from the operations background, business background. We do not have value trainings and processes. So that's a mindset issue, which you look at the hospitals, you look at the TPAs, insurance companies, it's the state governments. Now they are having a dedicated SNA team. Earlier when the scheme started, nobody had any team of any kind. And you to go to the village to speak local language, to enroll beneficiaries by a trained resource is a huge challenge even today. Trust me, enrollment, which we think is a very easy exercise, where the thumb impression doesn't work, when the card is put or the photograph does not, is hardly visible. So these are the capacity building issues which are faced by various people, various stakeholders. Controlling fraud and abuse. This is emerging to be a very big area in itself, and we last month only we have conducted a workshop of all the insurance companies, and we have taken out some triggers. The good part about RSBY is that every data flows on spot. So there are you can do a lot of initiative on the technology side. A lot of triggers and alerts have been built which kind of highlight the outlier cases, which can then be verified and investigated further. And of course, quality of healthcare and smart cards. I think one worry is that when hospitals have priced the healthcare so low, when they are performing cesarean section at 5,000 rupees, what kind of quality of care is that being compromised? So there is an initiative on grading of hospitals on quality of care itself. So these are some of the recent initiatives: outpatient pilot, grievance portal. Everything has been brought online. Every hospital can lodge a grievance which will be addressed within 30 days. There is an evaluation agency's quality criteria, GIS mapping of hospitals. Not all hospitals should be in one area and others are without hospitals. So GIS mapping of hospitals is being done. Depanelment process has been started. Enrollment quality, there is a change in the process whereby giving the card to the beneficiary on spot has become very, very necessary. These are some of the pilots, I think, with Janshri Bima Yojana or PDS in Chhattisgarh. This is being done. Just 2 slides left. Expansion of RSBY, it is already expanded to BPL, above BPL, NREGS workers and other occupational categories. As per the President of India's speech, 70 million families by the end of 12th plan is the plan. And RSBY's role, I think, it plays on the secondary healthcare. It has a good platform, ready platform to scale up. Additional segments of population, whether funded by the government or self-paid, can be added. Technology platform to stitch together different pieces of healthcare delivery are there. Standardized medical procedures are there. Transparent administration at low cost. I don't think a scheme of this size has run on such a low operating cost. And it has, I think, 1,500 crore is the total outlay of RSBY. I don't think there is any scheme more efficient than this. Repository of data is available. Thank you very much. Thank you.
Okay, thank you very much. This is Malati Jaswal for this point of view from the health insurance industry.